Hello everyone. In this video we would be taking a look at anemia in pregnancy. This is a general overview of anemia in pregnancy, and in next set of videos we will be taking a look at IDA 2. So that is a separate section because it is big, but in this video it is just anemia where it contains all the anemias. So what is the definition and classification of anemia in pregnancy? Defined as condition where the hemoglobin concentration in the peripheral blood is 11 gram per deciliter or less, wherein hematocrit is less than 32%. Due to plasma volume expansion, hemoglobin below 10 gram per deciliter is considered anemic at any point in pregnancy. So this is these two, better to include both of these. The World Health Organization defines anemia as hemoglobin below 9, which requires further investigation, evaluation and treatment. Anemia is responsible for 20% of maternal deaths in third world countries. So better to include all of these. So overall it is 11 gram per deciliter. Due to plasma expansion, if it falls below 10 gram per deciliter, it is considered anemia at any point in pregnancy. The WHO defines anemia as hemoglobin below 9. So before we go on further, let's go to ChatGPT and get a proper so let's go over here. What exactly is the definition? Textbook mentions all three. Let's see. ACOG less than 11 gram per deciliter in the first and third trimester due to physiological hemodilution. Second trimester due to maximal volume expansion, lower cutoff is 10.5. WHO less than 11, moderate is less than 9 and severe is less than 7. 11, 9, 7. And clinical practice, it is less than 10 at any point, often considered clinically significant. So I'll just copy this and put it somewhere so that it is useful in future, in case you would like to learn about this in the future. So I'll put it anemia general. So next, coming back. Coming to the classification. So we have physiological and pathological anemia. First one we know it already, we have seen it, due to hemodilution and negative ion balance. Pathological anemia, deficiency anemias, hemorrhagic anemias, hereditary anemias, bone marrow insufficiency, anemia due to infection, chronic disease related anemia, hematologic malignancies. So first one, deficiency anemia. There could be iron, folate, B12 and protein deficiencies. We know the mechanisms already, so anemia should be a very quick chapter to finish, except the management part where it is different for pregnant females. Overall, but it should be faster. Coming to hemorrhagic anemias, due to acute bleeding or chronic bleeding. Acute bleeding could be secondary to antepartum hemorrhage, postpartum hemorrhage. Chronic could be due to hookworm infestation, bleeding piles, heavy menstruation before pregnancy. Coming to hereditary could be thalassemia, sickle cell, spherocytosis. We have seen this repeatedly in so many pediatrics medicine. Bone marrow insufficiency, hypoplasia, aplasia due to radiation, chemotherapy and or infections. Hypoplasia, aplasia, chemotherapy, infections. Due to infections, separate section, malaria, TB, Kala Azar. Chronic disease related, renal disease, neoplasms. Hematological, there are leukemias and lymphomas. Now coming to etiology. So this was the classification. Etiology is somewhat similar, but it is a different way of classifying it. So etiological classification: due to increased demand for iron, nutritional deficiencies, malabsorption syndromes, blood loss and hemolytic disorders. So first one, increased demand for iron. Iron requirement increases to 18 to 20 milligrams per day. 18 to 20 milligrams per day. So this is a key point. And high demand in twin pregnancies, short interpregnancy interval and adolescent pregnancies. So in this particular case, this is the kind of anemia that we see. Next, coming to nutritional deficiency. So we have seen it already. Low iron absorption. In addition to that, low iron absorption due to excess phytates, oxalates, tannins in diet, malabsorption syndromes including intestinal infections, chronic diarrhea, chronic gastritis and pernicious anemia. So all these things can impair absorption. Coming to blood loss, we have seen it already. Hookworm, menorrhagia prior to pregnancy, this is a different one, and APH and PPH. Coming to hemolytic disorders, so sickle cell, thalassemia, hereditary spherocytosis all lead to hemolysis, and autoimmune hemolysis also can happen in SLE, G6PD, HELP syndrome. So we have seen the etiology of anemia in pregnancy. So even if you have some broad overview, you can write something in this particular section. Coming to clinical features, we have seen this repeatedly, these features. Again, I'll just go through it. General symptoms, signs on examination. General symptoms include fatigue, pallor, weakness, dizziness, shortness of breath, palpitations, headache, koilonychia, which are spoon-shaped nails, heelitis, glossitis, that is in IDA. Neurological symptoms, paresthesia, ataxia and vitamin B12. In considering the signs, pallor of mucous membranes, conjunctiva, skin, systolic murmur due to high output circulation, pedal edema, tachycardia, splenomegaly. So all of these we know. I am not delving into this much further because this is very simple. Coming to diagnosis and investigations, yeah. So not jumping into these directly. First we start from CBC. Hemoglobin less than 11, RBC less than 4.5 million per mm cube. Then there are different indices MCV, MCH, MCHC to classify types of anemias: microcytic, normocytic, macrocytic, and then peripheral smear. So microcytic hypochromic in iron deficiency anemia, macrocytic vitamin B12 or folate deficiency, and cystocytes in hemolysis. And there are others too, but mostly in pregnant females we look at these things. Coming to iron studies, serum ferritin, TIBC and serum iron. So in case of IDA, less than 30 microgram per liter, that is serum ferritin. TIBC is increased, total iron binding capacity. So I am not going to mention the reasoning behind this because it has already been mentioned in pediatric section, and you can just copy this and put it in ChatGPT. It is very simple. Serum iron also low, so even this one makes sense in case of IDA. B12 and folate low in megaloblastic anemia. Reticulocyte count elevated in hemolytic anemia. And compensatory mechanism, anyways I'll explain this one also. TIBC is increased. Why? Because the total iron binding capacity, so capacity to bind iron is increased. What does that mean? Because iron itself is less, so capacity for it should be increased. It's just 4 to 5 seconds, so it is fine if I explain. Yeah, coming to bone marrow examination, done in severe or refractory cases. Yeah, so that is it. So bone marrow is always the last resort. Coming to the management of anemia in pregnancy, that is so in the question it was mentioned during labor / 28 weeks. So now we look at general measures, then iron therapy, and then we look at management in labor. Then finally we look at prevention. So general measures: nutritional supplementation, balanced diet with iron rich foods, liver, green leafy vegetables, red meat, fish, eggs. In case of infections, treat them, deworming, UTI treatment, and blood transfusion if less than 7 gram per deciliter in symptomatic patients with hemodynamic instability. Iron therapy, this has been given in much more detail in the next section, iron deficiency anemia. But just for completion sake, we are doing this oral iron therapy because anemia in general topic can also come, and also iron deficiency anemia also can come as a 10 marker. So both of these are included. So oral iron therapy, ferrous sulfate 100 mg daily should be continued 100 days postpartum, 100. Vitamin C for iron absorption. Parenteral iron, if it is less than 7 gram per deciliter. IV sucrose, iron sucrose 100 mg every 3 days till total dose is completed. 100 mg every 3 days. 100 mg every 3 days. Next, coming to blood transfusion, severe anemia, hemoglobin less than 6 gram per deciliter with cardiac decompensation. 6 gram per deciliter with cardiac decompensation. Folic acid therapy 5 milligram per day in folate deficiency or high risk pregnancy. 5 milligram per day in folate deficiency or high risk pregnancy. B12 100 microgram IM daily for 1 week, then weekly for 4 weeks. 100 microgram IM daily for 1 week, then weekly for 4 weeks. Erythropoietin therapy used in renal disease induced anemia. Erythropoietin used in renal disease induced anemia. So these were the management in case of iron therapy. Yeah. Next, coming to, it was in general actually. Yeah, coming to management of labor in anemic pregnant woman. So first stage, then second stage, then third stage. So first stage, oxygen therapy via nasal cannula, strict asepsis to avoid puerperal infection, IV fluids and monitoring. Second stage, prophylactic vacuum forces assisted delivery to shorten the labor, injection oxytocin 10 international units IM post delivery to prevent PPH. So mainly we are looking at to reducing the shortening the duration of second stage and also to prevent PPH by injecting oxytocin. Third stage, monitor PPH and transfuse blood if needed, packed RBC transfusion for hemoglobin less than 7 gram per deciliter. So these are the stages of management of different stages of labor. Coming to the prevention of anemia, there is iron folic acid supplementation, deworming, correction of nutritional deficiencies and health education and family planning. First, IFA 100 milligram iron plus 500 microgram folic acid. 100 milligram iron, 500 microgram folic acid daily from 14 weeks to 6 months postpartum. 14 weeks to 6 months postpartum. Deworming albendazole 400 milligram single dose in second trimester. 400 milligram single dose in second trimester. Correction in nutritional deficiencies, high iron diet including meat, fish, poultry, legumes, green leafy vegetables. Health education and family planning. Encourage spacing of pregnancies at least 2 years. So between every pregnancy 2 years of gap. Avoid teenage and frequent pregnancies. So everything makes sense. This one also is fine. So this one is proper intuitive understanding of how to go about things. Only this one is a dose. These three doses 100, 500 microgram and again 400. And here it is clear we want to maintain oxygen supply. Here it is shortening of duration of labor and preventing PPH overall, and then transfusion if it is extremely bad. And over here too we have seen different kinds of iron therapies and also folic acid and vitamin B12 supplementation. And probably this should include these two things, iron therapy and blood transfusion, and rest of the things should come in separately. I'll try to change the format in case the time permits, or else it is obvious how it is, how if you go on understanding it properly. Then overall it is quite fine. It is a very simple topic, but only thing is we need to know how to put the headings, subheadings and write things. So in case you like this particular video, you can like it. In case you would like to learn more about such things, medicine related topics, you can subscribe to this channel. And then that's it. Bye bye.